So we're going to move on to how do the Medicare Advantage encounter data arise. Medicare Advantage has been around for a while. The encounter data has been around for less time. During this segment, we're really going to try to cover why the encounter data are submitted, how they're submitted, and when they are submitted. And also, we kind of talk about this in relation to fee-for-service data. We're often used to thinking about healthcare claims data, and encounter data are different than that, and we'll talk about why that is. So Medicare Advantage encounter data, in 2009, the Inpatient Prospective Payment Rule, CMS clarified their authority to ask for individual service reporting from Medicare Advantage organizations. They asked for this for dates of service beginning January 1st, 2012. You can imagine this is a bit of a lift. However, the Medicare Advantage organizations were administering their plans. They had to figure out how they were going to get service level data to CMS. So there was some delay in getting all of the information from the plans. And then we also have, the data quality concerns. So they were finally released to researchers in 2015. It was decided that kind of we hit a decent amount of encounter data submission. CMS has a lot of reasons for wanting encounter data. One of the primary ones is trying to understand how best to pay Medicare Advantage organizations for the individuals that they serve. Remember, they're paid a capitated payment, so they want to kind of calibrate that payment correctly. So the encounter data gets put into the risk adjustment models. And that also was phased in over time. It wasn't right away in January 2012 that all of the encounter data was used. That's been a phased in process. But Medicare also, for coverage evaluations, quality review, and for us doing research, it's really great to have be able to peek into that black box that we didn't see into before. So how is an encounter different than a claim? We're used to thinking about claims, or at least I am, as a request for payment. The provider is billing directly to the payer, and in Medicare fee-for-service, they're billing the Centers for Medicare and Medicaid Services. They said, we've delivered this service, and they're requesting payment for it. An encounter instead is a description of the services that were provided, and it's not a direct record of payment transactions. So it's documents, what were the diagnoses associated with the service? What were the procedures, including, just a physician visit that were delivered to Medicare Advantage beneficiaries. Encounter records are conceptually different than claims, but we really kind of use them the same way. Oftentimes, that's what we're doing with claims, is we're trying to figure out who's using the services, what kind of diagnoses do they have. And it's also important to note, encounter records are not necessarily a record of payments, but of services provided. So if the Medicare Advantage organization has denied the service, they're required to submit all Medicare covered services. But let's say it was an automobile accident and the Medicare Advantage organization isn't liable, they still should be submitting the encounter to CMS, just to say that, yes, the service was provided to this individual. All plan types that are grouped as managed care are required to submit encounter records, but it might vary by plan type in terms of what they submit. They're generally required to submit all Medicare covered services, but some plans will submit different, will provide services that are above and beyond what Medicare covers, like the program for all-inclusive care for the elderly. They are really only responsible for submitting Medicare covered items. On the other hand, for Medicare Advantage organizations that kind of offer a supplemental vision benefit, they should be submitting all services. That's kind of that first line. Cost plans, we mentioned, they are responsible for part of a Medicare beneficiary's care. So whatever part they're responsible for, they need to submit the data. But some of the beneficiary services will actually be billed directly to CMS, and they can be found in the fee-for-service data. You may have seen, now that encounter data research is getting out there, researchers may be limiting to particular plan types. And the reason for that usually is about kind of how the plan is administering the benefit and what they're required to submit. So it's not that they're not required to submit, but there may be reasons to to limit. So how is the data submitted? They're actually the same forms as fee-for-service claims. And this benefits us if you're used to working with fee-for-service data because the fields look very similar. The structure, whether it's an institutional form, and institutional means it's a facility that was delivering the care, a facility that's generally also responsible for Part A. Even if they perform a Part B service, that will get kind of grouped into the institutional files and use the institutional claim form structure. Professional and durable medical equipment suppliers use a different form. So the variables available and kind of the structure of those claims is different, but it will be the same kind of difference as we see in fee-for-service. There are basic minimum data elements that are required. They may change over time. We have the Encounter Data Submission and Processing Guide, but in general, who is the provider that's providing this service? This is something that we get really good information on, like the organization MPI is required, and we have that. Sometimes the individual provider is less populated on Encounter Data, but what were the diagnoses associated? What were the procedures that were delivered? What were the dates? All of those things are going to be well filled in the data. And like with fee-for-service claims, if you start looking into it and you say, oh, that's interesting, they ask for a certain piece of information that I don't see on the research files, that happens sometimes. We don't put the beneficiary's full address on our research files, even though that's something that's collected on claim forms, that sort of thing. So the research files, really the service is delivered at the provider level. They work with the managed care organization for payments. It's actually the managed care organization that's submitting the encounters to the Encounter Data system. And then from there, CMS houses the Encounter Data system. It goes into their internal data repository and can be separated out for the risk adjustment payment system. We're mostly concerned with the data then that they pass on to the chronic conditions data warehouse. Also, we refer to them as CCW. They are actually the data distributor, and they create the research files for us and distribute the files. ResDAC helps you request the data, but when you're receiving the data, you're actually working with CCW on that. The Encounter Data files, as I mentioned, are very similarly structured to the fee-for-service data. Facility data are facility form data are the inpatient, outpatient. Outpatient is a Part B service in Medicare, but it's usually performed by an institution that also delivers Part A services. So inpatient, outpatient, home health, and skilled nursing facilities are all in the facility format, and carrier and DME carriers would be professional claims like physicians, nurse practitioners, that will show up in the carrier data, and the DME is the durable medical equipment. There are two types of records that are included in Encounter Data. Remember, this is the plan explaining to CMS, this is what the patient has required and what kind of diagnoses they have. So there are service records, which are, generally have a procedure code associated with them, and the procedure can be just a physician visit. It could be a CPT code for a physician visit or a surgery or a lab. And then there are chart review records. So chart review records are medical record reviews of individuals that might be enrolled in a managed care organization. They're performed for validation of diagnoses to make sure that an accurate count of diagnoses and accurate diagnoses are getting put into the risk adjustment system. They're submitted using the chart review encounter record, but it's going to look the same in terms of the fields associated, looks the same as these service records. Becky will be talking about how you can kind of identify these in the data. They must be supported by the medical record, and managed care organizations could use it to remove a diagnosis if upon chart review they realize it was billed incorrectly, but by far it's mostly used to add diagnoses, and that's of course to communicate to CMS that their payment maybe needs to be a little bit higher. And so that would be the primary use of chart reviews. For encounter service records, adjudication is what we think of as kind of the back and forth between a provider and their payer to get a service paid for. So, sometimes the provider will bill, the payer will pay, end of story. Sometimes the provider bills, the payer maybe pushes back and says, I need more evidence. That's not the proper diagnosis in order to deliver this service. There's some back and forth in terms of what gets paid, or sometimes the payer may say, oh, we're not actually liable, it belongs to somebody else. What should be delivered to the encounter data processing system is the final status of that adjudicated claim. Now, sometimes an adjudicated claim, it's the final status is approved or it's denied, and maybe a replacements claim will be submitted. That we kind of get a lot of data on that within the encounter data processing system. Whereas with fee-for-service, we always say, well, the research files contain final action claims. Final action is really all of the adjustments, even if it's multiple steps, are rolled up into a single record that's either a full payment, a partial payment, or a denial. So with fee-for-service, we typically see one record per claim. And it does include denied claims. With the encounter data, there is an indicator for final action, but that doesn't necessarily mean that is the only claim associated with that service. So it's possible that there was a final action claim that was denied and they submitted a second one for the same service that was paid. We would see probably both of those claims. There isn't an indicator for denials. So the bottom line is that you might see multiple records for the same service. You can identify this by the diagnosis and procedure codes, the dates associated, the provider. And we don't have a standard methodology that we can give you. I will say that deduplication has already been improving over time in terms of what gets delivered to researchers, but CMS doesn't want to do too much of it. They don't want to be making your decisions for you. So you may have to make some of your own decisions considering the goals of your research. I apologize, I have too many slides for the time. In terms of submission, managed care organizations have 13 months from the date of service to submit the service record. And that's why, as researchers, we have a bit more of a lag than we do for other records in terms of getting the data delivered to us as research files. So just recently, they released the preliminary file for the 2020 data. CMS does want to make records available in a timely fashion, so they've moved to this preliminary and final file format. The preliminary file will contain all the records for 2020 dates of service, and it was created as of spring 2022. Now, you may say, well, that's seems like more than 13 months, and there was a little bit of a shift in the length of time they allowed managed care organizations to submit. So the submission window actually closes in August of 2022 for the 2020 dates of service. And we will see that then after that file, after all the submissions have come in, when that's processed. And that should be viewed as a replacement for the preliminary file. If you've received both, you can just take the final file and say this replaces the preliminary. Encounter data likely captures most services that are provided to managed care enrollees, and it's going to continue to improve over time as managed care organizations get more familiar, as researchers start using the data and ask questions, and then as risk adjustment becomes more reliant on the encounter data. We have some considerations that, we have preliminary and final files that you are going to have to navigate, the combination of encounter and chart review records. There is a unique key, and Becky will talk about this later about, how to think about how the files actually look and how to think about them. But there is going to be some level of deduplication that will be needed. I haven't left a ton of time in terms of before the break, but I will stick around during the break to answer questions. I think I saw that there were a few, or there's quite a lot of activity in the chat. Let's see if there's something that I can. I see one of the first questions was about the physician NPI not being filled. And, part of this may have to do with the way that the managed care organization is paying for the service. They may be just paying a clinic, a capitated rate that the clinic is then paying their physicians out of. So they may not have collected the individual physician's information, which is why we don't see it on the data. There is going to be variation probably by plans in that, but it is definitely a limitation that we've found with the encounter data. So the question is, there's no indication of denial, but there is indication of final action. There is, although remember, final action kind of means something a little bit different. You still might see 2 final action records that have the same dates and diagnoses and procedure codes. You may have to think about, like if it's a physician visit, you might say, oh, well, maybe they saw 2 different physicians on the same day, even if it's because we don't have individual physician MPI. But you might, if it's 2 radical prostatectomies, you might say, I'm just going to roll that up and count it as 1. So it does take some decision making as you're using the data to think about. The final 2020 encounter data will be released after it's processed. I don't have an actual date associated with that, but it's I don't want to give I think there's like a 6-month usual difference between preliminary and final release, but it might be more than that. So please don't hold me accountable for that. So we will be kind of going through, so in August is when that's the final cutoff that encounters need to be submitted by August in order to be entered into the risk adjustment payment system. But then the files need to be processed in order to deliver to researchers. So that just takes a little bit of time. Yes.
Oh, yeah, there's a question in the chat asking about duals and what services might be missing from encounter data for duals.
Yes, I apologize.
Oh, go ahead.
There was a note that I was going to cover. The encounter data processing system is only covering, or it's only getting the Medicare covered services. So like if there was nursing home use, for example, we wouldn't see that in the encounter data. That would be something that would be covered in the Medicare or the Medicaid data system. So that's one type of thing that you might be missing. If it's something that's like Medicaid only covered, that's something that you wouldn't necessarily see in the encounter data.
And the Part D file includes MAPD, Part D claims, correct?
Yes, it does.
Yes, yes. That was another question, so yes.
Yes, and so ever since Part D has been available, we have had some managed care information for the managed care beneficiary, or some utilization information for beneficiaries, but it was limited to prescription drugs until 2015. So if most drugs are covered by Medicaid, so duals are actually automatically enrolled into Part D, but if there are, differences in terms of coverage, you may see things in Medicaid that you don't see in Medicare.
There are some questions about how if you can tell if an encounter record was covered or paid. I think it's a little tricky, and maybe Steph, you could chime in. We don't have the same sets of variables in encounter data as fee for service. And, I think we still at ResDAC have questions as far as if you're able to tell that as well as, in fee for service data. I believe that the MAOs should submit encounters that are covered, but as far as if they were paid or not, I'm not aware of really clear way to find that out in the encounter data. I don't know, Steph, if you have anything more to add there.
Yeah, unfortunately, we haven't seen a great way of doing that without, and even if there were payment information, sometimes the payment information that Medicare Advantage plans are able to send it's just different. It's not going to be service level necessarily, depending on how they pay their providers. So so that wouldn't necessarily even be helpful, but we don't have a good way of doing it now. I think oftentimes we are more interested in whether a beneficiary used a service. So that, but if you're trying to figure out, well, how are Medicare Advantage plans deciding, you know, in general, if it's covered by Medicare, we assume that they're paying it, but we won't know if we don't see, you know, if they've sent it off to a different insurer, we wouldn't necessarily see that another insurer had paid for that Medicare covered service. But if we're, you know, mainly interested in whether or not a beneficiary received the service, luckily the data is good for that. Yeah, so thank you. There are a lot of zero pay encounter records, and I think part of that is related to how plans are paying providers as well. And then a workaround for the physician MPI field. Unfortunately, we haven't done a lot of work with it. I'm not aware of something if other people have looked into it. There is an organizational MPI, like I said, so you might be able to tell whether or not they, you know, it's a particular group of physicians, but it could be possibly, you know, probably any number of physicians within that organization. So that's, I think, what we've come to with that. I apologize for taking up the entire break here. Are there other questions that
there are some more questions coming through. If you feel like there's time, but so someone's asking if there's any plans to decrease the time to submit encounter data, which is month.
I'm not aware of any.
Okay, all right, that's our answer there.
Mm-hmm.
Yeah, I think we've covered most of the questions. If we've forgotten any, please let us know in the chat.
Oh, I see one question about completeness of skilled nursing and home health care services.
Oh, yes.
Yeah, on the course website, I did put a couple of the MedPAC reports. They outline some of the things that they've done to assess the completeness. One of the things they did with skilled nursing is to try to link it with the MDS data, and home health care similarly link it with the OASIS assessments that have been collected by CMS historically. And so there's more information on that. I think that they end in 2015. I think that it's probably improved slightly over time. Like a very quick look that we had done looked like maybe just trying to match assessments, and home health was like 80%. But again, that was like very brief, and OASIS assessments aren't necessarily visit level either. So it was just like, if a beneficiary has an OASIS assessment, can we find a home health claim kind of thing, or a home health encounter? But so you can look at that 2015 number in the MedPAC report as probably a baseline. Yeah, so the question is, can encounter, SNF, and home health be linked to MDS and OASIS? And yes, so the CMS MDS, that's the minimum data set. Those are nursing home assessments. If you request them through CCW, they'll come with a beneficiary identifier, and the encounter data also have a beneficiary identifier, so you can use those to link in order to get more information. So you can see that. And MDS, yeah, you can kind of see, you know, nursing home use over a period of time. The assessments are required at certain points within their nursing home, and it's MDS is all payer, so it has historically included Medicare Advantage as well.